Welcome back to the deep dive. Today we are really getting into it with the body's largest organ.
The integumentary system. Skin, hair, nails, the whole package.
Exactly. And our sources today, they are dense. It's a really high-yield guide to dermatological diagnosis, but honestly, it can be overwhelming.
It definitely can. Derm conditions are tricky because, well, you see them right there, but so many look alike.
Right.
So the mission for you listening in isn't just about memorizing names. It's about spotting those subtle but crucial differences.
The clues.
The clinical cues, yeah, and understanding the mechanisms underneath. That's what lets you really separate one thing from another.
We're hunting for those key differentiators. The things that, change everything in how you think about a case, moving past just knowing the definition.
Right, from observation to true understanding of the why.
So how are we tackling this mountain of information?
Okay, so we've tried to map it out logically. We'll start with some chronic issues, things affecting nails and hair, think growth cycles, infections.
Makes sense.
Then we'll shift to structural problems like scaling disorders, where the skin's barrier is the main issue.
Got it.
And finally, we'll look at acute rashes, the ones driven by viruses or immune reactions.
Perfect roadmap. Okay, let's dive in, starting right out of the edges, nails, on onychomycosis. So onychomycosis, fungal nail infection. Super common, right?
Mm-hmm.
But the sources seem to stress it's more than just, how it looks.
Oh, absolutely. That's the critical piece. It might seem like just a cosmetic problem, but it can pose a real systemic risk, especially for certain vulnerable patients.
How does it start? What's actually happening in the nail?
Well, it usually begins as this chronic invasion of the nail plate itself.
Yeah.
And the main culprit, overwhelmingly, is a dermatophyte fungus called Trichophyton rubrum.
T. rubrum. Okay.
Yeah, this fungus specifically likes keratin. It basically eats the protein that makes up your nail.
Ah,
And as it digests that keratin, you get all those typical changes. The nail gets thick, rough, maybe crumbly underneath, and you see that classic yellow or brownish discoloration. Onychodystrophy, technically.
but the danger.
Yeah.
You mentioned systemic risk. How does a fungus in my toenail lead to something serious like, say, cellulitis? That seems like a big leap.
It does, but think about the nail plate's job. It's supposed to be
Yeah.
a barrier, right? Impermeable.
Right.
When T. rubrum sets up shop long-term, it messes with the nail structure, the nail bed underneath. It creates these tiny cracks, microfissures, and breaks down the skin around the nail, like the cuticle.
So it creates an opening.
Exactly, an entry point. And bacteria that normally live on the skin, like staph or strep, they're opportunistic. They see an opening, especially on the foot, where things might be, less clean or circulation isn't perfect.
Like in diabetes?
Precisely. Diabetes, peripheral vascular disease,
Yeah.
those patients are at higher risk. The bacteria get in through those fungus-induced cracks and can cause a nasty soft tissue infection, cellulitis, and that can escalate quickly, even become limb-threatening.
Wow. Okay, so treating it is actually preventative medicine, not just vanity.
You got it. Especially in those high-risk folks.
So, given the stakes, how do we make sure it is fungus and not something else that just looks similar? Can we just tell by looking?
Definitely not. Appearance alone is unreliable. The sources are crystal clear on this. The best initial test, the gold standard really, is KOH microscopy.
KOH prep.
Yep. You scrape some of that debris from under the nail, dissolve the keratin part with potassium hydroxide, that's the KOH, and then look under the microscope. You're looking for the fungal elements, the hyphae, or spores. That confirms it.
Okay, KOH prep. And if that's positive, the treatment, you mentioned it takes commitment. 12 weeks of oral terbinafine for toenails. Why so long?
It's all about the nail growth cycle. Oral antifungals like terbinafine, they get incorporated into the nail matrix, the root where the new nail is made.
Ah, so it grows out with the new nail.
Exactly. You have to treat long enough for the healthy drug-infused nail to completely replace the infected part. Fingernails grow faster, maybe 6 weeks is enough, but toenails, they crawl, maybe in a millimeter a month. So to get full replacement and saturate the tissue, you need that sustained 12-week course. And even then, the sources are honest, recurrence rates are frustratingly high.
Right. Which brings us back to those mimics. How do we quickly rule out the other possibilities, the wrong options for the learner?
Crucial skill. You need to spot the red herrings. Okay, first, if the nail has a distinct green tint, chloronychia, think bacteria, specifically Pseudomonas aeruginosa, often happens when moisture gets trapped.
Got it. Green equals Pseudomonas.
Pretty much. Second, if you see tiny pits in the nail surface or the nail lifting off the bed, that's onycholysis, or those weird-looking oil spots underneath. That's not fungus. That points strongly towards psoriasis.
Psoriasis, okay. Different mechanism entirely.
Totally different, immune-mediated. And third, think about location and exposure. If it's mainly the fingernails and the person have their hands in water a lot, bartender, healthcare worker, you might suspect Candida albicans. It likes wet environments, unlike T. rubrum, which prefers drier keratin.
Okay, that's super helpful. Green, pseudomonas, pitting spots, psoriasis, fingernail sweatwork, candida.
Nail it down like that and you're on the right track.
Great clarity. All right, let's shift gears to another area that causes a lot of anxiety. Hair loss. The alopecia complex. It feels confusing because there are so many potential causes.
Hormones.
Immune system, stress.
It is confusing. So let's try to map it out by the underlying cause, the mechanism. But first, maybe a quick primer on the hair cycle itself. That kind of sets the stage for all three types we'll discuss.
Yeah.
So hair isn't just constantly growing, it cycles through phases. There's anagen, that's the active growth phase, lasts for years usually. Then catagen, a short transition. And finally telogen, the resting or shedding phase, lasts about 3 months.
Anagen, catagen, telogen, growth, transition, rest.
Exactly. And all the hair loss types we're covering today basically involve messing up the timing or synchronization of these phases. Hashtag 1.2.1 female pattern hair loss, FPHL.
Okay, let's start with the most common one. Female pattern hair loss, or FPHL. We often think hormones, right?
Mm-hmm.
But the sources seem to add some nuance, especially for women.
They do. The core mechanism is follicular miniaturization. The hair follicles shrink, producing finer and finer hairs. Now, in men, it's clearly linked to androgens, DHT specifically. In women, it can be driven by excess androgens, like in PCOS.
Polycystic ovary syndrome.
Right, you always check for that. But often, women with FPHL have totally normal androgen levels. It's considered idiopathic.
So not always hormones.
Not always directly driven by excess hormones, no. But the result is the same physiological process. A progressive, steady shortening of the anagen phase. The growth phase gets cut short over and over.
And visually, that creates a very specific look, doesn't it? It's not just random shedding.
Not at all. The pattern is key. You see this gradual thinning that starts right around the vertex of the crown and along the midline part of the scalp.
The part gets wider.
Exactly. But here's the crucial diagnostic clue, especially compared to male pattern baldness. The frontal hairline is typically preserved. It doesn't usually recede from the front like you see in men.
Okay, thinning on top and midline, but the front edge stays put. No inflammation, no scarring either, right?
Correct. Scalp looks normal, just less hair density in that specific pattern.
So, treatment aims to counteract that shortened growth phase. Topical minoxidil is first line. Why minoxidil? Wasn't that originally a blood pressure drug?
It was, and that history actually helps explain how it works. It was developed as an oral vasodilator for hypertension.
Right.
Patients started noticing hypertrichosis, extra hair growth as a side effect, so they reformulated it as a topical.
Clever.
The exact mechanism on hair is still debated, but we think it works partly by increasing blood flow via vasodilation, but more importantly, it seems to directly act on the hair follicle cells to prolong the anagen phase. It physically keeps hairs in the growth phase longer, fighting that miniaturization process.
So it's directly intervening in the hair cycle itself. Makes sense. What about finasteride? That's common for men.
Right. Finasteride works by blocking the enzyme that converts testosterone to DHT, which is the main driver in men. In women, since FPHL isn't always DH2-driven, and because finasteride carries risks for women of childbearing age, it's teratogenic. It's usually a second-line option. May be used if there's proven high androgen levels, but minoxidil is the go-to first step. Hashtag 1.2.2.2 alopecia areata, AA.
Okay, switching gears completely now from that gradual pattern loss to something much more sudden and targeted. Alopecia areata. You describe this as an immune assault.
It really is. This is classic autoimmunity. Specifically, it's believed to be a T-cell mediated attack. Your own immune cells, these cytotoxic T lymphocytes, mistakenly target the cells in the hair bulb right at the base of the follicle.
Ouch. Sounds destructive.
It sounds like it, but here's the crucial silver lining. The attack is usually aimed at the bulb cells, not the follicle stem cells. This means the follicle itself often remains intact. It's damaged, but not destroyed, which is why regrowth is possible.
Okay, potential for regrowth. That's important.
Yeah.
What does this T-cell attack look like on the scalp? How's it different from FPHL?
Dramatically different. AA presents as patchy hair loss. Often these patches are perfectly round or oval, and they can appear quite suddenly.
Patches, not diffuse thinning.
Exactly. And critically, the hair loss is painless and non-scarring. If you look at the skin within the patch, the scalp itself looks completely normal. No redness, no scaling, no inflammation. It just looks like hair is missing.
Smooth, normal skin in the patches. And isn't there a very specific type of hair you look for, the diagnostic clue?
Yes. The classic physical exam finding, exclamation point hairs.
Right.
If you look carefully, right at the edge of an active patch, you might see these short, broken hairs that are thicker at the top, distal end, and taper down to a narrow base, proximal end, just like an exclamation point.
Why do they look like that?
Because the immune attack is happening at the root, weakening the hair shaft as it emerges, so it breaks off, leaving that tapered end near the scalp. Finding those is highly suggestive of AA. Also, a positive hair pull test, gently tugging a small bunch of hairs near the patch, and seeing if more than 5 or 6 come out easily indicates active shedding.
Okay, patchy, smooth scalp, exclamation point hairs. And because it's autoimmune, does it travel with other autoimmune conditions?
Very frequently. This is a huge point for you, the learner. Finding AA should always make you think about screening for other autoimmune issues. It has known associations with thyroid disease, both Hashimoto's thyroiditis and Graves' disease, and also with vitiligo, the autoimmune condition causing skin depigmentation.
So seeing AA might be the first sign of a broader autoimmune tendency.
It absolutely can be. Management focuses on calming down that local immune attack, usually with topical or sometimes intralesional injected corticosteroids right into the patches. Hashtag tag 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 1.2.3 telogen effluvium.
All right, our third pathway, telogen effluvium. This one isn't structural like FPHL can be, and it's not an immune attack like AA. You called it a systemic shock to the system.
Think of it like the hair follicle's emergency response. Something major happens in the body, and a large number of hairs that were happily in their anagen growth phase get prematurely kicked into the telogen resting shedding phase all at the same time.
So instead of shedding happening gradually, a whole bunch decide to fall out together.
Exactly, a synchronized shed. And this requires a pretty significant physiological or emotional stressor. The patient's history is absolutely key here.
And the timing is important too, right? The hair loss doesn't happen during the stress, but later.
Correct. Typically, the shedding starts about 2 to 4 months after the triggering event, so you need to ask about stressors in that time frame.
What kind of stressors are we talking about?
The sources list things like a serious illness, especially with high fever, like the flu or, COVID-19 recently, major surgery, significant weight loss, or nutritional deficiencies, starting or stopping certain medications, particularly hormonal ones like birth control. Childbirth is a classic trigger that postpartum shed many women experience as TE, and severe emotional trauma can do it too.
Okay, so a major event precedes the shedding by a few months. How does the shedding itself look different from FPHL or AA?
It's acute, comes on relatively quickly, and it's diffuse, meaning the hair loss is spread out all over the entire scalp. It's not patchy like AA, and it's not concentrated in the FPHL pattern.
It's just general thinning everywhere.
Yeah, patients often report seeing noticeably more hair in the shower drain or on their brush, sometimes alarming amounts. But like AA, the scalp itself looks completely normal. No inflammation, no scaling, just increased shedding of normal-looking telogen hairs, the ones with the little white bulb at the end.
That diffuse pattern is key. And the good news here, the main message for the patient.
The absolute best part about TE is that it's self-limited. It stops on its own. Once the body recovers from the initial stressor, the hair cycle naturally resets.
So reassurance is the main treatment.
Pretty much. Education and reassurance are critical. Let the patient know why it's happening and that it will stop, usually within 3 to 6 months after it starts. Regrowth typically becomes visible within 6 to 12 months. Trying aggressive treatments often just adds more stress.
Okay, that's a great way to frame it. Let's quickly recap the distinctions. A, patchy, autoimmune, look for exclamation points. FPHL, pattern thinning on top midline, gradual due to shortened anagen phase. TE, acute, diffuse shedding all over, triggered by a stressor a few months prior, and self-limited.
Perfect summary. Mechanism really dictates the pattern.
Okay, we've covered appendages. Let's move to the skin itself. We're now looking at conditions where the skin structure, its barrier function, is the problem. First up, ichthyosis vulgaris. Sounds dramatic. Fish scale disease.
It does sound dramatic, and visually it can be, but it's a fantastic example of how a single genetic issue can cause a widespread skin problem. Ichthyosis vulgaris is chronic, inherited, and usually shows up in infancy or childhood.
Inherited. So what's the core defect?
It boils down to a protein called filaggrin. In ichthyosis vulgaris, there's typically a loss-of-function mutation in the gene that makes filaggrin. Either you don't make enough, or the filaggrin you make doesn't work properly.
Filaggrin. Okay, what does filaggrin normally do? Why is losing it such a big deal for the skin?
Think of your top layer of skin, the stratum corneum, like a brick wall. The skin cells, keratinocytes, are the bricks. Filaggrin, its name, comes from filament aggregating protein, acts like the mortar and like a built-in moisturizer.
Mortar and moisturizer. How?
Okay, two main jobs. First, it helps bundle keratin filaments inside the skin cells, making them flatten out and pack together tightly. That's the strong barrier, the mortar. Second, when filaggrin breaks down, its components form what we call natural moisturizing factors, or NMFs.
Okay.
Yes, these are substances like amino acids, urea, lactate. They're crucial for holding onto water within the stratum corneum, keeping it hydrated from the inside out. That's the moisturizer function.
So no functional filaggrin means the wall is weak and leaky and it can't hold its own moisture.
Exactly. The skin cells don't compact properly, and they don't shed normally either, leading to a buildup of dead cells hyperkeratosis. Plus, without those NMFs, the skin becomes chronically dry and rough. That buildup and dryness create the characteristic fish scale appearance.
Makes sense. Now the pattern, where do you typically see these scales? That's key for diagnosis, right?
Absolutely critical.
Yeah.
The pattern is very distinct. You see dry, fine, often polygonal scales looking a bit like fish scales, mainly on the trunk, and very importantly, the extensor surfaces of the arms and legs, think shins, outer arms.
Extensors, like the outside surfaces.
Right. But here's the absolute giveaway. Ichthyosis vulgaris characteristically spares the flexural folds.
Spares the bends, like elbows, behind the knees, armpits.
Exactly. Those areas usually look normal or much less affected. It often spares the face, too. This distribution is completely different from, say, eczema. Oh, and it tends to get much worse in the winter when the air is dry. And you might also see palmar hyperlinearity, extra prominent lines on the palms.
Okay, extensor scales spares the flexures, worse in winter.
Got it.
Since the problem is literally a missing structural component, how do you manage it? Can creams even help?
Basic moisturizers are essential, but they're often not enough because they just add moisture externally. You need to address the scale buildup too. The best approach involves hydration plus helping the skin shed properly.
How do you do that?
Long baths or soaks can help hydrate and loosen the scales. Then you follow up with special moisturizers containing keratolytics.
Keratolytics. Keratin dissolvers?
Pretty much. These are ingredients that help break down the glue holding those excess dead skin cells together. Common ones are urea, lactic acid, which is an alpha-hydroxy acid or AHA, and sometimes salicylic acid, a beta-hydroxy acid or BHA. They soften the keratin and promote normal shedding.
So hydrate, then use urea or lactic acid to break down the scale. That makes the difference from atopic dermatitis, eczema, really clear then. Eczema loves the flexures and is super itchy.
Exactly. If it's mainly flexural and itchy, think eczema. If it's extensor, scaly, spares the flexures, think ichthyosis vulgaris. And it's also not psoriasis.
Right, which has much thicker silvery plaques. Let's move on to that now. Hashtag 2.2, small plaque psoriasis.
Okay.
Psoriasis, another scaling condition, super common, chronic. But unlike ichthyosis, which is inherited structure failure, this is an immune system problem, right? An acquired issue.
Absolutely. Psoriasis is fundamentally an immune-mediated disease. The T cells are the main culprits again.
Those T cells are busy.
They really are in dermatology.
Yeah.
In psoriasis, T cells get activated and release inflammatory signals, cytokines that basically scream at the skin cells, the keratinocytes, to grow like crazy.
Hyperproliferation.
Massive hyperproliferation. This leads to the skin thickening, which we call acanthosis, and that rapid turnover is why you get the characteristic scales.
How rapid is rapid? What's the comparison to normal skin turnover?
It's dramatic. Normally, it takes about a month, say 28 to 30 days, for a keratinocyte to be born at the bottom layer, mature, and shed from the surface.
Okay.
In an active psoriatic plaque, that whole process is accelerated down to maybe just 3 to 4 days.
Wow, from a month to less than a week.
Yeah. The cells are dividing and moving up so fast, they don't have time to mature properly. They just pile up on the surface as thick scale.
That explains the thickness. Now, the sources mentioned something really interesting. The Kubner phenomenon. What is that, and how would you see it?
Ah, cubnerization. It's fascinating. It means that psoriasis can develop in areas of skin that have been injured or subjected to friction.
So trauma triggers a plaque.
Exactly. If someone with psoriasis gets a cut, a scrape, a surgical scar, or even just constant rubbing from, say, a belt or tight waistband, they can develop new psoriatic lesions right along that line of injury. It shows how reactive the skin is in this condition.
Okay, now we're focusing specifically on small plaque psoriasis. How is that defined, and where does it typically show up?
Right, because psoriasis can present in many ways. Small plaque psoriasis just refers to lesions that are generally less than 1 centimeter across, but they still have that classic look, sharply defined, red erythematous plaques covered with those characteristic silvery white scales.
Less than 1 centimeter, but still look like psoriasis. Where do you find them?
They can pop up in many places, but common spots include the scalp, the backs, dorsal surfaces of the hands and feet, the trunk, and sometimes in the gluteal cleft.
Dorsal hands and feet. That seems like a key location.
It can be helpful for differentiating, definitely.
And like other immune conditions, we need to think beyond the skin, right? Associated conditions.
Absolutely. Psoriasis isn't just skin deep. A significant number of patients, maybe up to 30%, will develop psoriatic arthritis, which is an inflammatory arthritis that can affect various joints. And you often see nail changes too, the nail pitting and onycholysis we mentioned earlier when differentiating from fungal nails.
So always check joints and nails. How do we distinguish this small plaque type from seborrheic dermatitis? Sebderm is also common, scaly, hits the scalp.
Good question. They can overlap, especially on the scalp. Two main clues, the type of scale and the distribution. Psoriasis scale is typically thick, dry, silvery white, and really stuck on there.
Silvery and adherent.
Yeah. Seborrheic dermatitis usually has a greasier yellowish scale and distribution. Sebderm loves areas rich in oil glands, scalp, eyebrows, creases beside the nose, chest. While psoriasis can be there, small plaque psoriasis often hits non-sebaceous areas like the dorsal hands and feet, places sebderm usually spares.
Greasy yellow scale in oily areas versus silvery scale potentially on dorsal hands, feet.
Got it.
Okay, final section. Let's shift to more acute rashes, starting with erythema multiforme, or EM. This sounds dramatic too. It's an immune reaction, but acute, not chronic like psoriasis.
Exactly. EM is an acute, self-limited, immune-mediated reaction pattern in the skin. And the single most important thing to know, the highest yield fact for you, the learner, is the trigger.
What's the trigger?
Overwhelmingly, it's herpes simplex virus, HSV.
Cold sores, genital herpes.
Either one. More than 80%, maybe even 90% of EM cases are preceded by an HSV infection, usually about 1 to 2 weeks beforehand. Even a really mild cold sore that the patient barely noticed can trigger it.
1 to 2 weeks later.
Okay.
And the mechanism. The source of stress is cell-mediated immunity. Why is that detail important, distinguishing it from, say, an allergy?
It explains the timing and the type of lesion. Think of allergies like hives, urticaria. That's often IgE antibody mediated. It happens fast, minutes to hours, because the body releases preformed mediators like histamine.
Right, immediate reaction.
EM is different. It's driven by T cells. The idea is that fragments of the HSV virus might deposit in the skin. Then specific T cells recognize these viral antigens and mount an attack against the skin cells displaying them. This T cell recruitment and activation process takes time.
Which explains the 1 to 2 week delay after the HSV outbreak.
Precisely. It's a delayed type hypersensitivity reaction mediated by cells, not immediate antibodies.
Okay, cell-mediated, delayed onset after HSV. What does it actually look like? What's the classic lesion?
The absolute hallmark is the target lesion. That's the money diagnosis.
Target lesion. Like a bullseye.
Exactly like a bullseye. These lesions tend to appear symmetrically, often starting on the extremities, hands, feet, arms, legs, and they can involve the palms and soles, which is quite characteristic. They're usually fixed, meaning they stay put, unlike hives, which migrate.
Okay, target shape, symmetrical on extremities, palm, soles. What defines a target? How many rings?
Technically, a classic target lesion for EM is defined as being less than 3 centimeters in diameter and having 3 distinct zones.
3 zones. Can you describe them?
Sure. Zone 1, the center, is often dusky red, maybe even purpuric, sometimes with a small blister or crust. That's the area of most damage. Zone 2, surrounding that, is a pale ring, often swollen, edematous. And Zone 3, the outermost ring, is bright red, erythematous.
The arc center, pale ring, red outer ring.
Got it. And systemically, does the patient feel sick? Usually not very. Maybe mild fever or feeling unwell, but generally systemic symptoms are minimal or absent. This helps distinguish it from more severe related conditions like Stevens-Johnson syndrome, where patients are quite ill.
Okay. Diagnosis is mostly clinical then, based on the look and the history.
Primarily clinical, yes. You see those target lesions, ask about recent HSV.
Mm-hmm.
Pretty straightforward, usually.
How do you manage it?
Since it's self-limited, management is mainly supportive. Symptom control. If there are painful mouth lesions, maybe an anesthetic mouthwash. Antihistamines might help itching. But the key management point comes in if it's recurrent.
If it keeps happening after HSV outbreaks.
Exactly. If someone has recurrent EM clearly triggered by HSV, the strategy shifts to preventing the HSV in the first place. That means putting them on suppressive antiviral therapy, like daily acyclovir or valacyclovir long-term. Stop the HSV, stop the EM, hashtag tag tag 3.2 plantar warts, verruca plantaris.
Okay, moving from immune reactions to viruses to infections by viruses. Plantar warts, caused by HPV, right? Human papillomavirus.
Correct. HPV causes warts. When they're on the sole of the foot, plantar surface, we call them plantar warts, or verruca plantaris.
How does the virus get in?
Through tiny breaks or abrasions in the skin. Think walking barefoot in communal showers, locker rooms, pool decks. Classic spots to pick it up.
Makes sense. And because they're on the sole, they get pushed inward, right? That's where they hurt.
Yeah, the pressure from walking flattens them and pushes them into the deeper skin layers, often causing pain, especially over pressure points. They look like rough, thickened papules, sometimes with little black dots inside.
Black dots, what are those?
Those are actually tiny, thrombosed, clotted capillaries within the wart tissue, and they are key to the diagnosis.
How so? Is there a specific test or maneuver?
There is. The single most useful diagnostic step, highlighted in the sources, is to pare the lesion.
Pare it, like shave it down.
Exactly. You carefully shave off the overlying thickened, hyperkeratotic skin with a scalpel blade. If it's a plantar wart, as you get down towards the base, you'll see pinpoint bleeding.
Ah, because you're hitting those little clotted capillaries.
Precisely. That pinpoint bleeding upon paring is virtually diagnostic of a wart.
Okay, that's the definitive move. How are they treated? Do they go away on their own?
Sometimes, especially in kids, the immune system eventually clears the virus and they resolve spontaneously. But if they're painful or persistent, treatment is often needed.
What kind of treatments?
Common options involve destroying the infected tissue, things like cryotherapy, freezing it with liquid nitrogen, or using topical salicylic acid, usually in higher concentrations than for cosmetic use, to chemically peel away the wart layers. Sometimes other destructive methods or immune therapies are used, but even with treatment, recurrence isn't uncommon because the virus can linger.
Okay. Now, the main thing people confuse these with is a callus, right? How do you use that pairing test to tell the difference?
Perfect question. A callus is just thickened skin due to pressure or friction. It's diffuse hyperkeratosis over a pressure point. When you pare down a callus, you just see more thickened skin until you reach the normal skin lines underneath. There are no capillaries running up into it like in a wart.
So no pinpoint bleeding.
Exactly. A callus does not show pinpoint bleeding when pared. That's the absolute differentiator. Bleeding means wart, no bleeding, just normal skin lines means callus. Hashtag 3.3 miliaria rubra, heat rash.
All right, last one. Let's shift to babies. Miliaria rubra, often called heat rash or prickly heat. Seems simple, but the sources have some key points.
It is common, especially in newborns and infants, and it really highlights how immature their systems can be. The basic problem is sweat gland obstruction.
Blocked sweat ducts. Why does that happen in babies?
There are crine sweat ducts. The little tubes carrying sweat to the surface aren't fully developed yet. Their opening onto the skin might be delayed or easily blocked. So if the baby gets overheated, too many clothes, hot environment, they produce sweat, but it gets trapped under the skin surface.
The sweat can't get out.
Right. The duct can rupture below the surface, leaking sweat into the surrounding skin, which causes irritation and inflammation. That's the rubra part, the redness.
Okay, trapped sweat causes inflammation. What does the rash look like, and where does it usually appear?
You see these tiny, fine, maybe 2 to 4 millimeters pink or red bumps, erythematous papules. They often look like little pinpricks, and the distribution tells the story. It favors areas where heat and moisture get trapped.
Like folds.
Exactly.
Yeah.
Intertriginous areas, the neck folds, armpits, groin. Also, areas covered tightly by clothing, like the back, chest, or scalp if they're wearing a hat. The key is that the baby usually seems fine, otherwise maybe a bit fussy from being hot, but not ill.
Okay, tiny red bumps in sweaty, occluded areas on an otherwise well baby. Management sounds like it should be straightforward then.
It absolutely is, and it's non-pharmacological, which is great. The solution is simply to remove the obstruction and cool the baby down.
So, less clothing.
Yes. Avoid overbundling. Keep the room cool. Dress the baby in lightweight, breathable fabrics. Cotton is ideal. Give them cool baths. Basically let the skin breathe and cool off. The rash usually clears up quickly on its own once the overheating stops.
Simple enough. But the sources include a critical safety warning about not using certain treatments. What's the danger?
This is really important. Because it's a red, inflamed-looking rash, people might be tempted to put steroid creams on it. But using high-potency topical corticosteroids on infants, especially over large areas like the back or neck where heat rash occurs, is a big no-no.
Why? What's the risk?
Babies have a much higher body surface area relative to their weight compared to adults. Their skin is also thinner and more permeable, so they can absorb a significant amount of that potent steroid right through the skin into their bloodstream.
Systemic absorption.
Yes. And that can lead to serious side effects like suppressing their adrenal glands, HPA axis suppression, growth issues, Cushingoid features, really nasty stuff. So for simple heat rash, cooling measures are the safe and effective approach. Avoid the potent steroids. Hashtag outro.
Wow, okay. We covered a lot of ground there, from chronic fungus all the way to simple heat rash. But running through it all was this idea of pinpointing the specific mechanism or the unique visual clue. If you had to boil it down, what are maybe the top 3 diagnostic pivots we hit today that you really want the listener to remember?
That's a good challenge. Okay, 3 high-yield takeaways. First, I'd say understanding the language of scale, recognizing the difference between that dry, filigrin-deficient scale of ichthyosis that spares the flexures versus the thick, silvery scale of psoriasis driven by T-cell hyperproliferation. Scale type and distribution tell you so much.
Okay, scale interpretation. What's number 2?
Second would be the power of a simple physical maneuver, carrying the lesion. Seeing that pinpoint bleeding to instantly confirm a plantar wart and distinguish it from a callus? Sometimes the answer is right there at the tip of your scalp.
Right, the hands-on clue. And third?
Third, I think, is grasping the underlying immune timing for erythema multiforme. Knowing it's a delayed T-cell mediated reaction, usually to HSV, helps you understand the timing 1 to 2 weeks post-infection and recognize those distinct target lesions, separating it from immediate allergic reactions like hives. Mechanism predicts the morphology and timing.
Scale language, pairing for warts, and immune timing for EM. Excellent. And it's really striking, as we went through these, how often a skin issue points to something deeper. Onychomycosis, risking cellulitis, alopecia areata linked to thyroid disease.
It really underscores that the skin isn't just a wrapping, it's an active interface, constantly reflecting internal states, infection risk, immune status, even genetic predispositions like with filigrin.
Which leads nicely into our final thought for you, the listener, to take away and maybe mull over.
We've seen these strong connections, T-cells driving hair loss in AA and being linked to thyroid issues or vitiligo, EM being a delayed echo of a latent virus. So the question is, how should this change our perspective on screening?
If the skin is giving us these visible clues, these early warnings about potential systemic inflammation or autoimmune processes, should we be more proactive?
Right. Should the appearance of, say, alopecia areata or maybe even certain patterns of psoriasis automatically trigger a baseline screen for related autoimmune conditions, even if the patient has no other symptoms yet?
Thinking of the skin not just as the site of the problem, but as potentially the first, most visible signal from the body's internal early warning system.
Exactly. How can we better use this incredibly accessible organ as a barometer for hidden systemic health issues? Something to consider.
Definitely something to consider. Thank you for guiding us through that intricate landscape, and thank you for joining us on this deep dive. Hopefully those key distinctions are a bit clearer now.